Left atrial appendage closure and non-warfarin oral anticoagulation have emerged as safe and effective alternatives to warfarin for stroke prophylaxis in patients with non-valvular atrial fibrillation. And in the December 22nd issue of JACC, investigators will be presenting data on time to cost effectiveness following stroke reduction strategies in AF, warfarin versus NOACs versus LAA closure. And there is an accompanying editorial comment, and so I am with the author of that, Dr. N.A. Mark Estes, the third MD. You are the director of the New England Cardiac Arrhythmia Center and a professor at Tufts University School of Medicine. A good pairing of papers. I really like this. Let's talk about some background first, though, before we jump into the papers, because this is an important topic.
Yes, it's a very important topic, and I appreciate the opportunity to comment on it. But certainly, as this audience knows, of the roughly 700,000 strokes each year in this country, a quarter of them likely result from embolic events from the left atrium. And in the past, the major strategy has been to use anticoagulants, with aspirin and Plavix being relatively ineffective and warfarin being the gold standard. More recently, there's been NOACs, the novel oral anticoagulant agents, which have come up and have consumed a large part of the market share. More recently, the left atrial occlusion device has been approved by the FDA, and the article that Dr. Reddy and his colleagues have published have gone beyond the clinical trials registries looking at effectiveness compared to warfarin and safety compared to warfarin. They're now looking at cost effectiveness, efficiency of the drug as well.
So what did they do? In order to do this, just go through the process of what did they do and what did they find?
Well, the first thing they did is to rely very heavily on the very robust evidence that had been built up over a decade with registries and prospective trials looking at the Watchman versus warfarin. They then modeled the costs of the procedure itself, the left atrial occlusion, and the long-term effect of it out to 20 years. Against warfarin, and then they used the NOACs. Now, importantly, they used indirect comparisons because, of course, there's been no direct left atrial occlusion versus NOAC or novel oral anticoagulant comparison. That's one of the limitations of the study. Nonetheless, they used very standard methodology looking at current costs for the procedure, current cost for the drug, efficacy and safety of both the drug and the procedure, and then projected that out over the next 20 years, essentially finding that the left atrial occlusion was cost-effective compared to warfarin at 10 years and compared to NOACs at as short as 5 years. It's the dominant strategy.
So at this point, how many patients do you suggest for a Watchman device?
Well, that's a question that I don't have an answer to now, and I think the clinical arena will really come close to that correct answer. I think certainly one group of patients that would be considered for the left atrial occlusion device are patients who have a very high risk of stroke, that is a very high CHA2DS2-VASc score, and also have a very high risk of bleeding, in whom warfarin or NOACs would be relatively strongly contraindicated. Now, whether there are other groups of patients in whom the trade-off in terms of safety and efficacy versus the NOACs is going to be consuming a large amount of the marketplace remains to be seen. Bearing in mind that, one, there's never been a direct comparison of the left atrial occlusion to the NOACs.
Correct.
We have had multiple trials looking at NOACs versus warfarin. We also need to bear in mind, too, that the costs that are currently used are projected over 20 years, and they may vary widely. In addition, the group of investigators who were in the trial with the left atrial occlusion device were experienced. They were very good at patient selection, very good at the technique of implanting the device, and the complication rates went down dramatically. Now, in the real world, when a technology like this is out in the clinical marketplace, we cannot assume that the rates of complications are going to be as low, that the outcomes are going to be as good. And importantly, too, another aspect of this is that in these trials, the warfarin was maintained in the therapeutic range a very high percentage of the time. So there are some limits to the data. It's an extrapolation, and those limits are recognized very nicely in the limitation section of that manuscript. But it brings to the forefront a number of other questions about applications of the left atrial closure device or other technologies in terms of training, patient selection, and follow-up.
And one of the things you pointed out too, because you talked about the procedure-related complications relating to the Watchman device, you note they predictably diminish in frequency with operator experience. Right. So hopefully the more they do, the better they'll get, and those numbers will become more like what you saw in the clinical trials.
That's correct. But of course, the complication rates in those clinical trials were the foundation for the cost-effective analysis. Right. And it is a real challenge to have new technology developed to educate physicians with respect to not only the procedure but patient selection follow-up, and have complication rates that are as low as there were in these experienced centers.
We know that with ablation there was a time when we thought that might cure it and you wouldn't need anticoagulation. Can most patients discontinue lifelong anticoagulation following Watchman implementation?
The best available evidence with limits on the outer range of the data would indicate that it is safe after a period of about 6 weeks of warfarin to discontinue it without an increased risk of embolic events.
Very good. Now, you concluded your editorial comment by saying, despite these unanswered questions, you say the evidence from the Watchman clinical trials and this analysis represents a meaningful progress in the quest for LAA closure as a clinical strategy for these patients.
Correct.
So you're pretty optimistic at this point?
Well, I'm optimistic in the following sense. The studies that were done with the Watchman were very well conducted. There was long-term follow-up, there's randomization, and over about a decade, the evidence that evolved was very robust that warfarin and the left atrial closure device, the Watchman, are comparable in terms of outcomes. So that evidence base, I think, is very, very robust. We don't have evidence versus the NOACs, right. So that's an unknown, and I think potentially direct comparisons of the left atrial occlusion device to the NOACs could be done. That would give us even better evidence. And importantly, too, any assumptions about costs currently and their costs in the future also have to be taken with the knowledge that they may vary quite widely, right. And they could go in either direction, making the more dominant strategy for left atrial occlusion or less dominant. And importantly, too, this issue about achieving the same excellent results in the real world that were obtained with the left atrial occlusion device is a real challenge. And I think that the manufacturers are looking at ways in which they can try to maintain those same standards through patient selection, center selection, training as well. So I think there is cause for optimism, but cautious optimism. And so far, the investigators, Dr. Reddy, and the company have done things right. And I think that their intentions are to continue to do it right, not get this device out and have results that are worse, meaningfully worse than they were in the trials.
Well, the main paper by Vivek Reddy et al. And the accompanying editorial comment by Dr. Estes, it is in the December 22nd issue of JACC. Please check both of those papers out. For CardioSource World News, I'm Executive Editor Rick McGuire.